Hi, this is Samuel Collins, your coding and billing expert for the H.J. Ross Company and the H.J. Ross seminars, but also just the coding and billing expert for chiropractic. In today's episode of ChiroSecure's Growth Without Risk, we're going to discuss coding and billing, but specifically evaluation and management codes, or E&M codes. And I want to get some details in what is included in the pre-service and the post-service work, because there's been a lot of issues come up recently where chiropractors have run into problems with billing exams but not demonstrating the separate, distinct nature. So I want to hopefully make that clear cut. I would say, please take some time to view, review, and then share with friends, because this is an area where there's been a lot of audits and a lot of chiropractors, unfortunately, getting themselves into some trouble, if nothing else, just reimbursement back to the insurance because it's not shown as separate and distinct. So let's go and go to the slides. Let's take a look here. Opening slide, just our chiropractic coding. Please note the email, or excuse me, my website. And again, what is included in the pre-service and post-service work of a CMT code? Well, let's start first with, when you do manipulation and an evaluation and management together, there's an inclusion. So you notice all of us, I'm sure, are familiar with billing the modifier 25. And here's the reason why. The CMT codes, meaning the adjustment codes, include a pre-manipulative patient assessment. Additional evaluation and management, or we say E&M services, may be reported separately using modifier 25 if the patient's condition requires a significant separately identifiable E&M service above and beyond the usual pre-service and post-service work associated with the procedure. Now, here's the part I want to be clear cut on. Certainly, there is an evaluation that occurs when you do a manipulation. That evaluation is inclusive, meaning the day-to-day. By example, on the first visit, when you see someone, you're clearly going to do a much more detailed exam, history and so forth of the patient. But when they come in for the second visit, you're going to do a short. You're not going to do a full exam, but a short exam. And that short exam is considered inclusive. And that's the reason for modifier 25. This is the reason, of course, when you don't bill with a modifier 25, it'll come back as denied, saying it's inclusive. So what does every chiropractor have to know? Okay, modifier 101 when we comes to CMT codes. There are 4, of course, CMT codes for chiropractic, 3 for spine, and 1 for extra spinal. And they're to assist us to make sure that they include the treatment we give, which means manipulation of the spine. It's divided into, of course, the number of regions manipulated, but I also want to indicate not just regions manipulated, but regions diagnosed. And so it says here, the work value of the CMT includes both cognitive, clinical judgment, and technical skill components, or a work unit of time, and it's divided into 3 sections: pre-service, intra-service, and post-service of the day of the CMT. So why I want to make sure there's a clarification, this new information, or more detailed, I should say, is coming from the CPT assistant, the November of 2018, and it goes into the much more details about what this includes, because I do believe we've had some confusion as to how much do we include as part of it. As a generic rule, I would say probably each day that a chiropractor adjusts likely might be doing a value of a 99212. Therefore, not until you go above and beyond that would it qualify beyond just part of the treatment. So what does the pre-service work include? So this means before you adjust the patient. Physician's review of the patient's records to establish a treatment plan and to familiarize himself or herself with the previous treatment. So think of it, that couple of minutes you do either before going into the room, while you're in with the patient, going over their notes quickly before you even ask any questions. You may, of course, even review some prior imaging or other tests that you may receive. And of course, consideration of the range of possible treatments. Of course, likely you're going to manipulate, but it just goes into getting yourself ready to say, what are we going to do with this patient? Explanation of the procedure to the patient, and obtaining a verbal consent, and answering any additional questions or comments. What I would say here is the pre-service, probably simply put, is that little review of the chief complaint and how the patient is doing since the last visit. So in the simplest terms, I think the pre-service is the S portion of the SOAP note. A review of the chief complaint, changes since the last visit, system review if relevant, and of course, answering questions of the patient. So understand that this type of evaluation, or history, if you will, is included in the adjustment code, hence the 25 modifier. So that's going to be the pre-service. The intra-service work includes performing a pre-manipulation patient assessment. Now, this means the things that you do normally, you may assess the patient's pain level. You're going to look at objective signs. Maybe you're going to do some palpation. Maybe you're going to do a range of motion. Maybe you do motion palpation. Maybe you look at leg length. Any of those objective factors that you do, of course, document. But again, that's part of the day-to-day adjustment. I know many chiros who often will do at least a leg length check, some probably range of motion to the segments they're going to adjust, along with palpation of spasm or tenderness. So in other words, you're going to identify what's going on with the patient. And again, this is part of the treatment. This is not above and beyond. This is part of what we do. It's not the first visit exam, but part of what we do. And then, of course, the treatment procedure that best fits the patient's condition is finalized, meaning the intraservice is really part of the work we do and includes the adjustment part. I would say the simplest way of thinking of this is the O section for the most part. It's the exam of the area of the spine or region of complaint. It doesn't always have to be spine, of course. Chiropractors can treat beyond spine, but it's involved in the diagnosis and assessment of change in the patient since last visit. I'm going to emphasize here, make sure you're documenting not just change in pain, but also changes in function or something that's tangibly measured, such as a range of motion. And then, of course, you're going to evaluate just the treatment effectiveness. So again, this is just part of the normal day-to-day visit. So in other words, there's a small exam first, how are you feeling, then evaluation of the area and the adjustment. This post-service, though, after we've adjusted, this is possibly after the patient leaves, but isn't necessarily. Realize chart documentation is part of the patient visit. I would suggest do it with the patient there, finish it and be done. But if you sometimes later do the chart documentation, that does not increase the value of the service. You've just decided to do it at a different time. It also could be for follow-up consultation, arrangement of services with another provider, discussion with the family members. So notice here, reporting examples, written and telephonic communications with the patient or family or other professionals. So realize that post-service is pretty large. So again, just be careful. Do not bill a separate E&M unless there's something significant and above and beyond what you would do normally day to day. The first visit certainly makes sense, but follow-up visits, you have to make sure that there's something beyond. So an exam billed with a CMT, we have to be sure there must be a separate and distinct issue above and beyond the associated level of evaluation with the adjustment. So the regular day-to-day things you do for an adjustment is just part of it. Make sure if you're going to bill for a separate exam, be sure there is documentation that clearly demonstrate it is beyond what is documented day to day. In other words, I think simply put, when you're billing an exam, the note should have much more detail and likely be more broad than would be the day-to-day. Then you're going to go back through the full how are you feeling and go through every aspect instead of just a quick review. I would suggest when billing a re-exam, the use of a history update or an examination form can aid in separating the visit clearly from what's done day to day. So by example, take a look at your notes. If within your notes, you can see a lot of detail on the day-to-day visit, and then when you do a re-exam, it doesn't look any different, it's certainly going to be hard to designate that day as a separate, distinct exam. Make it clear that it's above and beyond by, I would assume, a greater level of history, a full history, if you will, of how they've been doing. I would say a full detailed exam examining all the areas that we did initially so we can make a full comparison, not just those areas. And then, of course, likely going to be a separate treatment plan. So again, make sure the notes clearly show the separation. We've dealt recently with offices who've been audited, and unfortunately, their day-to-day notes were so detailed, which is good. When they billed for a re-exam, it simply didn't look like it was a re-exam. It looked like nothing more than what they've done on the previous visit. So we want to make sure that you can demonstrate above and beyond. So now here are some obvious examples of when you can do a re-exam. Clearly the initial visit, including the history exam and evaluation report of findings, clearly number one is going to be, of course, something you can do and has no issue putting the 25 modifier, because certainly that's above and beyond the routine. But a routine re-exam to evaluate the patient's response plan is generally about every 30 days. Now, again, that comes from basically CMS and other insurance guidelines, even workers' comp, that says a patient under an ongoing treatment plan should at least have an evaluation every 30 days. So certainly at every 30 days, it would not be unreasonable to bill an exam, but again, make sure that exam is clearly above and beyond the day-to-day. Now, what about beyond just the first visit or a routine re-exam? How come at times it can be sooner? Well, here's one. A sudden change in the patient's symptoms. Let's say the patient is coming in for low back pain, and then suddenly they come in complaining of they have some abdominal pain associated with that that's new, or maybe pain radiating down the leg. So something that's a sudden change and significant change, it would not be unreasonable to do an evaluation that day because that's going to be above and beyond just what the patient normally comes in for, such as simple low back pain. But also, and obviously, number four, a new incident. If you have a new incident or injury involving the same area or a new area, that certainly would require to determine that there's a newer change diagnosis. So again, patients coming in maybe for headaches and neck pain. After a week or 2 weeks of care, they state, hey, my neck pain is doing really good, but oh my goodness, last night I twisted my back and oh, my low back is killing me. Well, clearly that is a new problem. We have to evaluate that problem. Now, I won't say that's going to be the highest level of exam because we've done so many of the history that with this patient before. We just need the history of this level, but it's clearly above and beyond and appropriate for a 25. Make sure that it's clear that your example of an exam shows it's clearly separate and distinct. Now, the resources here that I've taken from are not my own. The resources, of course, are from Current Procedural Terminology, CPT, the Healthcare Common Procedure Coding System. I've taken it from the Centers of Medicaid and Medicaid Services, as well as Chiropractic Manipulative Treatment and the CPT Assistant, which just came out. And then further from the Margolin book for physician coding and reimbursement way back from 2007. What I want to make sure is that if you are doing an exam and billing separately, just make it clear that it's above and beyond. That's the issue many of us have run into, is not making sure that it's clearly above and beyond. It shouldn't be complicated. However, it is going to be more than what you would normally do. Obviously, chiropractors have to examine a patient to check their progress, but the day-to-day examination is inclusive. When you're billing a separate one, make sure it's clear. You cannot bill an exam daily because it's part of the overall services. Now, I hope this helps. It gives you a little bit more information on what constitutes an exam or separate and distinct and above, but make it simple. Do your notes appear that it's separate and distinct? So thanks for spending some time. Please take a look. We're on several places. We are on Facebook, Twitter, Instagram. Just go there, give us a like. What that like will do is allow you to get information from us. We post things about updates. We obviously do this show with ChiroSecure, and we're happy to do it. But we want to make sure you have always the most up-to-date information because we assure and want you to be compliant. Compliance means not only doing care for your patient well, but making sure we're also compliant on the coding and billing rules. Our job at H.J. Ross Company is to do that. So just give us a quick follow. Otherwise, thank you for being with me at this time. Next week's host will be Sherry McAllister. So stay tuned. Sherry will be up next week. And again, thanks for your time, and I wish you all the best.